Our next speaker in this section is Dr. JYOTI MATALIA, who would be talking on ocular myasthenia gravis, diagnosis and management. She is a senior consultant in pediatrics and neuro-ophthalmology department of Narayan Nethralaya hospitals with a brilliant academic career and innumerable teaching winning videos up her sleeve, besides many more of her achievements. On to you, Doctor.
Thank you. Can you hear me?
Yeah.
Yeah. So at the outset, I'd like to thank AIOS, ARC, and Dr. Chitra for this opportunity. I'll be talking on ocular myasthenia diagnosis and management. Talking first about what it is, the definition, the pathophysiology, why it is important in terms of the diagnostic steps and management. So let's come to the diagnosis. So we are aware it's an autoimmune disease that affects the neuromuscular junction, and primarily important for ophthalmologists because it affects the orbicularis oculi muscles, the extraocular muscles that you can see here, and the levator, right? So why it's important to know the pathophysiology is because our next steps are going to be on based on this. So as we are aware, the acetylcholine, the neurotransmitter, which is released at the junctions, that binds to the receptors of the muscles and results in contracture. But in myasthenia, there is presence of acetylcholine receptor antibodies, which bind to these receptors and result in their destruction. That's one. Another important aspects are the presence of the muscle-specific kinase and the LRP4, which is important for normal clustering of these receptors. And if that is destroyed by antibodies, which tends to happen in myasthenia, that will result in destruction of the receptors. And both these form the basis of the diagnostic tests. So what are the tests then? We'll classify them into these 5 groups. First, the clinical, very important variability. So history, which is very important, neuro-ophthalm is mandatory. You have to ask the diurnal variation that happens. They classically present with ptosis, which could be unilateral or bilateral. Diplopia, any form of cranial neuropathy, when doesn't fit into the normal routine, should be thought of myasthenia. So patient can present with diplopia, and most importantly, pupils are normal in these cases. Then the important test, that is a fatigue test, where when you ask the patient to look upwards, a sustained up gaze will cause the ptosis to worsen. And then the pathognomic test, the Cogan's lid twitch test, which means if you make the patient look from down gaze to up gaze, you'll see the sudden twitch that tends to happen in the eyes. After that comes the important other tests in the clinic. One is the eyes test, simple and very effective. After giving lice, applying ice for about 2 to 5 minutes, you will see an improvement in the ptosis. The sleep test, or the rest test, which allows resolution of the ptosis or ocular motility after 30 minutes. Then the short-acting and long-acting anticholinesterase treatment, which you give to see the sudden improvement in the ptosis. This has a sensitivity of 95% in GMG, but only 86% in ocular myasthenia. Then coming to the important serological tests, there's, yes, acetylcholine receptor antibodies, more specific, but normal titers does not exclude a disease. It is more so for the generalized myasthenia, but for ocular, only 50% tend to have positive tests. The others are MuSK antibodies and the LRP4 antibodies. However, remember that 10% of cases of ocular myasthenia can have triple negative, means all 3 antibodies absent. Then comes the electrophysiological tests. Yes, the single fiber EMG, which is the most sensitive, but not very specific, and more so for the generalized myasthenia, and the repetitive nerve stimulation study. And other tests that are important is the CT chest to rule out thymic hyperplasia, thymoma, and also do thyroid function tests. So when you have done these tests, finally we plan the management, which depends on 2 ways. One, is there any treatment which increases the acetylcholine availability at the junction? And secondly, prevents acetylcholine receptor binding with the antibodies. And that is done with pharmacological agents. Yes, pyridostigmine or mestinon, which is a prototype drug, and acetylcholinesterase inhibitor, which causes prolongation of the action of acetylcholine. So the first level of principle works here. It does not affect the natural disease course, but works only in 20 to 40% of patients with ocular disease. Then corticosteroids, which is the second line of treatment and should be given along with pyridostigmine. So if you have a patient with OMG, you can give both simultaneously. It can give about 80% of relief or the clinical symptoms. And finally, the immunotherapeutic agents, which are reserved for those when corticosteroids risk exceeds the benefit. It reduces the risk of developing generalized myasthenia, and it changes the natural course of the disease. A study by Sai Sommer et al. Showed that 12% of OMG patients develop GMG as against 64% who are not on immunosuppressants, which could be either because of late referral or uncertain diseases. So what are these agents? Yes, azathioprine, which works both for ocular and generalized, but has its side effects. Then mycophenolate mofetil, which is more effective in ocular myasthenia. And these two sets, which are primarily for the generalized myasthenia. Surgical options are reserved for those which are more commonly for generalized myasthenia, where we are looking at a presence of thymoma. And in those which are seropositive cases, if you are not responding to medical treatment, can also benefit, but not more than 50% of those with ocular myasthenia. So then, to summarize, you have to look at a clinical examination, eyes test, sleep test, fatigue test, rule out generalized symptoms or any alternative disease. If that clinically proves ocular myasthenia, yes, go and do the antibody testing. As mentioned, acetylcholine receptor antibodies are only positive in 50%. If negative, then the mask antibodies, but they are positive only in 5%. NLRP4 antibodies in 20% if the above two antibodies are missing. If they are seronegative, then you go to the electrodiagnostics, which is the RNS, and there's a decrement more than 10% from the first and the fourth action potential, then it's significant. And the single fiber EMG, look for the abnormal jitter, though not pathognomic, is definitely significant, and intermittent impulse blocking. If this is consistent, or if antibody testing is seropositive, then we are reaching the diagnosis of OMG. But if negative, then we have to look at other causes like MRI, find out something else, and it may not be myasthenia, or consider empirical treatment. It may respond, that also confirms it, and repeat antibody testing, which may come positive after 6 to 12 months, which finally would give us the confirmation. Hence, to summarize, remember that myasthenia is a clinical diagnosis. It's a great mimicker. So any patient who has a ptosis or diplopia, especially with normal pupils, suspect OMG always. Remember that importance should be given to the history of variability and fatigability. Don't get biased by diagnosis elsewhere. Always treat it as a fresh patient and treat it right, starting from the scratch with a good history and examination, and always coordinate with the neurologist, because many a times this could not be purely ocular. In about 50 to 60% patients develop generalized. But remember that if more than 2 years of patient having purely ocular symptoms may not go into generalized myasthenia, but always best to coordinate with the neurologist. So thank you for your patient listening.
Thank you, Dr. Jyoti. That was a wonderful talk, and that's nothing less is expected from you. And since you say serology is going to be only 50% effective in ocular myasthenia, I just wanted to know, would you think of doing an imaging of the mediastinum for a thymoma in these cases, or you would not?
So I would, as I said, in case of ocular myasthenia, I'm not very, if you're purely looking at an ocular cause, I'm not really very keen. In cases which are not responding on medical treatment, I would really look for. But if I'm forwarding this patient to a neurologist, then they always would look for thymoma.
Dr. Murli? Murli, you're muted.
I have a question for Dr. Satyakarna and Dr. Gordon. Actually, it has been said that steroids, even though they are first line in myasthenia gravis with ophthalmoplegia, they can produce a transient initial worsening. So some people actually start with a low dose of steroid and then increase it and then taper it down to the minimal dose that is effective. So is that the way to go, that you start with a low dose and then increase it so that you don't get the initial transient worsening? And how important is it in ocular myasthenia gravis? Because worsening of condition in generalized myasthenia gravis would be bad. So you would not like to start with a high dose of oral steroids, but for ocular myasthenia gravis, how important is it?
You want to answer?
Yeah, go ahead.
I think that it depends a little bit how long the patient has had symptoms, because we know that if symptoms have been purely ocular certainly for 2 years, it then becomes very unlikely that it would become generalized. So there isn't that risk, and so you can. But I don't usually start people on a milligram per kilogram straight away. Anyway, I build up the dose. But if they've only had ocular symptoms for a matter of weeks, they could become generalized very rapidly. And there I would be more cautious and probably admit the patient to start them on steroids if that's what I was doing at that point. But usually with purely ocular, you're quite a long way down the line before you start using steroids, corticosteroids anyway. And if there's a transient worsening of purely ocular myasthenia, it's not going to be a disaster. Do you agree, Dr. MATALIA?
Yes, absolutely. In fact, there's one study called as Epitome study, where they've studied the efficacy of prednisolone in the use of ocular myasthenia. And they have started with 5 milligram and gradually increased every 5 days to see whether you get the effect. And they found that they have separated with placebo, 0 of placebo out of 5, and so out of 6, and 5 of the 6 patients who got prednisolone got a significant improvement. And they finally found that 50 milligram per day was a good dose because they started increasing it and they titrated to this value. So if you want to get a good relief of symptoms, 15 milligram per day is what they found as an effective dose for treating these patients. And once you get a resolution, then you gradually start tapering them.
And so, but if you're really sure it's purely ocular, you can escalate the dose as tolerated, I think, and as an outpatient. But if there's any question that it might be generalized or any evidence that it is generalized, then you have to be more cautious. With regard to thymic imaging, do remember that there are thymic carcinomas, I think that all patients with myasthenia should have mediastinal imaging, and the problem we have with the trials is that, like Newsom-Davis trial of thymectomy, which was finally done, sadly he died before it was finished, but unfortunately they've always excluded ocular myasthenia from those trials. They've only looked at generalized myasthenia. So we don't really have the evidence, but I think that thymomas do need to be removed, partly because ultimately they'll cause other problems. They're also associated with other autoimmune diseases. One of my patients, he had a tiny thymoma, and I just thought I'd monitor it, and he developed red cell aplasia. It's terrifying. You make no red cells at all. You make and his hemoglobin dropped by 1 gram every day in that situation. So thymomas not only cause problems locally, they also are associated with a lot of other autoimmune diseases, which can be very serious, and occasionally they're carcinomas. So I think everyone with myasthenia should have mediastinal imaging. As you're saying, that's what the neurologists would say as well.
Thank you very much, Doctor. Thanks a lot.